I'd like to thank the organisers of BDER 2022 for the invitation to speak at the meeting. My name is Professor Steve Bain. I'm based in Swansea University Medical School in Swansea, South Wales in the UK. What I'm going to do is give a brief overview entitled Challenges in Recognising the Type of Diabetes at Onset. And this will be a rather clinically based talk, but hopefully introducing you to some of the nuances in the different types of diabetes that we now recognise. I shall just begin by showing you my disclosures. So the outline of the presentation is as followed. I'm going to give a very brief example of what the challenge might be in terms of recognising the type of diabetes. I'm going to talk about what are the various types of diabetes that we now have to consider. I shall mention the markers that help distinguish some types of diabetes from others, and I'll also mention at various times what are the benefits of actually making a firm diagnosis or recognising the different forms. And then finally, we'll have a quick go back to the case and decide how to proceed in this particular one and what the learnings have been. So the case, it's pretty straightforward. It's from one of my colleagues, Professor Jeff Stevens in Morriston Hospital in Swansea, a 36-year-old psychiatric nurse with a body mass index of 27 kilograms per meter squared is sent up to hospital with a capillary blood glucose of 28 millimoles per litre. He's apparently been complaining of lethargy, some increased thirst, and has been having to get up to pass urine twice per night for about 4 months. And as far as he's aware, there is no known family history. When he's seen, he has a plasma glucose of 27.8 millimoles per litre, confirming a diagnosis of diabetes. He has a near-patient plasma ketone of 1.4 millimoles per litre, which is on the borderline for diagnosing DKA, and he has an HbA1c of 11.5%, which is clearly elevated, and in the current UK units is 102 millimoles per mole. So this is a presentation. This is a sort of thing I'm sure many of us are rung up by our primary care colleagues on a Friday afternoon to say, what's the plan? Is this dangerous? What should we do about it? Does the patient need admission? So what is diabetes? Well, diabetes in 2022 remains a diagnostic umbrella, which is defined according to glucose levels. The two major types are type 1 diabetes, or insulin-dependent juvenile onset diabetes, as it used to be known, versus type 2 diabetes, or non-insulin dependent or maturity onset diabetes, which accounts for the vast majority of the cases. And I think until relatively recently, this was about it. Perhaps pregnancy related or gestational diabetes would have been regarded as a separate grouping, and perhaps pancreatic diabetes following pancreatitis would be regarded as separate, but the other types were relatively small print, and the vast majority of people would have one or other of these. It's important to say this isn't a new finding or a new recognition. Here's a publication that was from the British Medical Journal in 1951, and this was by a physician who is known as R.D. Lawrence. This was the first man in the UK to receive insulin following its discovery, and he was a physician in King's College Hospital and went on to inject insulin for the rest of his life. He was not only a famous physician, but he also led to the creation of the British Diabetic Association, which is now the charity Diabetes UK, with a colleague, H.G. Wells, who I'm sure you'll remember wrote the epic War of the Worlds. So Lawrence described these types of diabetes back then, although it didn't fully permeate into the clinical and the scientific literature, to the point when HLA was first being assessed as a possible risk factor, an etiological factor for diabetes. The original studies just lumped people with type 1 and type 2 diabetes together. And actually the first HLA studies of type 1 of diabetes were negative. But then, of course, in 1972, it was clearly shown in those with insulin-dependent diabetes have involvement, and indeed remains the major genetic contribution to the risk for type 1 diabetes that we know about. There's been a huge amount of work done on genetics of type 1 diabetes. I did my MD on it. I spent several years working in it, and we now have well over 40 other genetic markers that contribute to risk, but these are all establishing a sort of very minor additional risk, and in some of them it's very difficult to replicate them in different populations. And I think it's true to say that certainly in my practice, genetics has very little in the way of a regular routine diagnosis of type 1 diabetes. Antibodies, I think, have certainly changed in some respects. The original antibodies that were recognized in type 1 diabetes, establishing it firmly as an autoimmune disease, were islet cell antibodies. I think it's still not quite known exactly what the antibodies are to, but subsequently we've had anti-glutamic acid, decarboxylate antibodies, anti-GAD antibodies, which we now do use in practice. Insulin autoantibodies are also found, especially in younger patients with type 1 diabetes, and then more recently IA2A to antibodies to protein tyrosine phosphatase. And so there's a bank of antibodies that can be used to firm up the diagnosis of type 1 diabetes. Interestingly, the antibodies were also largely responsible for the identification of this subgroup of people that I think can be regarded as a subpopulation of individuals with type 1 diabetes. These are known as people with latent autoimmune diabetes in adult life, or LADA. And these were recognized as people who would initially be diagnosed as having type 2 diabetes, but over time they often progressed very rapidly towards insulin. And when this phenotype was examined in the UK PDS, you may recall the UK PDS was a study of type 2 diabetes, but the inclusion criteria allowed a significant group of people who were ultimately found to have LADA into that study. And on balance, they tended to be younger and leaner than those patients with typical type 2 diabetes, and as I mentioned, progressed more quickly through oral therapies to insulin than would be the case with type 2. And these can be defined as having anti-GAD antibodies. And so anti-GAD antibodies can be used as a guide in patients who are diagnosed where the phenotype doesn't seem quite right, to establish exactly whether it may be LADA or type 2. I have to say, though, the antibody titer in many cases doesn't reflect what's going to happen prognostically. So we were part of a study called Action LADA some years ago, and we had some patients who had extremely high anti-GAD antibodies that we felt meant that they would inevitably need insulin, and yet several years after the study completed, these patients are not all needing insulin study requirement. Type 2 diabetes is the diabetes that is currently being driven by the obesity pandemic. It's got high levels of concordance in identical twins, indicating that there's quite a marked genetic input into the condition. And like is the case with type 1 diabetes, there's been well over 40 genetic markers identified that appear to contribute to risk. However, unlike type 1 diabetes, there isn't one big area of the genome that is contributing, such as HLA, and so these genetic contributions are all extremely small. And once again, in my clinical practice, certainly there would be no place at present for routine genetic testing. Now, clearly this diagnosis does make a difference versus type 1 diabetes, because we not only have insulin as a therapy in type 2, but we also have other classes of glucose lowering therapies. At least 10 other glucose-lowering therapies are available in the United States, and these, of course, include drugs such as metformin and sulfonylureas, the TZDs, but also the largely injectable group of GLP-1 receptor agonists. You are probably aware that over the last 2 or 3 years, there's been attempts to subclassify type 2 diabetes. And this is a publication that came out last year from called the Rhapsody study that was using HDL cholesterol and C-peptide levels to try and differentiate between different cohorts of people with type 2 diabetes. And this was largely confirming an earlier study that had made this suggestion. So here we've got the group with SID, severe insulin deficient diabetes, those with severe insulin resistance, SIRD, the mild obesity related diabetes, the MODE, and then those with mild diabetes, either with high HDL cholesterol or those without a high HDL cholesterol. Now, it does get a little bit confusing in that the severe insulin deficient diabetes subgroup here have often got the presence of antibodies, and therefore there's this sort of merging between the type 1 diabetes LADA phenotype and this type 2 diabetes phenotype. And I'd also argue that at the actual diagnosis of type 2 diabetes, it's not really going to influence what you do, and you would inevitably, with most guidelines, end up starting these individuals on metformin unless they were extremely hyperglycemic. But a development that is certainly gaining some traction now. So what about diabetes that's got a very strong familial clustering? So this is a family tree of a pedigree that we previously met in the UK. And you can see here that the darkened areas for both males and females are those who have developed diabetes, and that this is a multi-generational thing. So a suggestion of dominant inheritance in that it's coming through from the grandparental to the parental down to the sibling generations. And this is a condition where people are being diagnosed at a young age, and so but it generally looks a bit more like type 2 diabetes than type 1. So this is the condition that gets termed MODY, or maturity onset diabetes, so like type 2, but affecting young people of the young. So generally the age cutoff arbitrarily has been less than 25 years. And you can see that there's quite a number of genes now. This is from a paper published last year showing 11 different MODY genes that have been identified. But I think if we simplify it slightly, I think the main ones that are being looked for these days are MODYs 1 through to 5. And in European Caucasians, at least, these genes account for over 80% of cases. Now, you may think it odd that the top gene is known as MODY 2, and then 3, and then 1. And this was on the basis of them being identified in pedigrees that had been known about. So the MODY 1 pedigree was a famous pedigree collected in King's College Hospital back in the 50s and 60s. And so that was regarded as the MODY 1 pedigree, but the gene, the hepatic nuclear factor 4 alpha, wasn't discovered until after glucokinase and HNF1 alpha. I'm going to talk a little bit about the different types of MODY, and I'm going to split them between those that are glucokinase and those that are not, so-called transcription factor MODYs. So MODY glucokinase is a mild, stable hyperglycemia. It's present from birth, and there is little or no deterioration with age. It's generally asymptomatic, and it's often undiagnosed until later life. It is familial because it's an autosomal dominant condition, as is MODY, but it's often not diagnosed as such because the symptoms are basically not present. And because it's a mild and stable hyperglycemia, diabetic complications are rarely, if ever, seen. So one might argue that it's a bit of a non-disease, really, and why would there be any value in diagnosing it? Well, the reason is that during periods of increased stress, so increased stress leading to increased insulin resistance, then significant hyperglycemia can occur. And the classic time this would be seen is in pregnancy. And back in the day, when the only treatment for diabetes during pregnancy was insulin, prior to metformin being used, these young females would often be put on insulin during pregnancy, and for some of them, they would remain on insulin for life on the basis that they had type 1 diabetes. But in fact, once this was recognized, then they could actually be taken off insulin subsequently. And so it did have an important clinical value. Has it led to a plethora of therapies? So if we know that a defective glucokinase gene is responsible for hyperglycemia, can we create drugs that affect glucokinase and therefore use these as therapies? And I think this is clearly been one of the aims of a lot of the genetic work in diabetes that has been done, but unfortunately in the case of glucokinase, it's been very disappointing. So on the top left here, you can see the original description of the glucokinase mutation by Philippe Frigel and colleagues in 1992, but the glucokinase activators that were subsequently developed have had a very poor longevity in terms of maintaining a reduction in glucose levels, and also have deleterious impacts on the lipid profile in patients receiving them. So as of this point, there is no obvious prospect of getting glucokinase related therapies. Looking at the transcription factor modi, so HNF, hepatic nuclear factor 1 alpha, HNF4 alpha, HNF1 beta, and IPF1, these individuals have got more a phenotype more akin to type 1 diabetes. So when they're born and in their early childhood, they have normal fasting glucose levels, but over time, the glucose levels rise. This can be sufficiently high to cause symptomatic diabetes, and ultimately they will be at risk of microvascular complications. As a result, they need to have their glucose brought down, and that can ultimately lead to the requirement for insulin. And the MODY1 pedigree that I mentioned earlier with the HNF4 alpha was indeed one of these pedigrees that did need insulin in the vast majority of the members of the family. There are subtle differences between the different transcription factor modi. So HNF1 beta, which is responsible, or known as MODY4, is associated not only with diabetes, but also with non-diabetic cystic lesions in the kidneys. So this diabetes insipidus is a syndrome related to this MODY gene, and indeed renal failure is a common outcome in patients with this mutation. Just to show that these things, albeit rare, do exist. So this is an HNF1 alpha family that is in my location in Wales in the UK. You can see the proband at the bottom right here, who was diagnosed at the age of 13 years, but because it was recognized he was part of a MODY pedigree, was treated with gliclazide, a sulfonylurea. And these patients with HNF1 alpha are particularly sensitive to sulfonylureas, and therefore it makes a proper treatment difference, because otherwise these individuals would almost certainly be treated with insulin. So an example in diabetes of precision medicine where a genetic genotype actually influences the therapies that these people receive. Here's another large pedigree. Again, it looks like it's going through the generations, so a very similar dominant type picture. But those of you who are particularly good at spotting things will note that the diabetics here the diabetes is being inherited only from the maternal line. And you can see that there are also other things being inherited with the diabetes when you see this sort of striped boxes. And this is a condition known as mitochondrial diabetes. Mitochondrial diabetes occurs because of mutations within the mitochondrial genome, and the mitochondrial genome, which is located in the tail of the sperm, is lost from the male parentage, but retained in the female egg. And so if it's only mutations within the female that are passed on to the offspring. And the commonest cause of diabetes due to mitochondrial disorders is known as 3243 mutation, and the associations here are not only diabetes, but also sensory neural deafness. This is a highly heterogeneous condition, even within the same family. So you might find an individual diagnosed with diabetes in their 30s and another individual with a mutation diagnosed in their 70s or 80s. And there's a condition known as heteroplasmy, which means that you have different concentrations of the mitochondrial mutation in different tissues, which means that if you've got a lot of it in your pancreas, then you become diabetic. If you've got a lot of it elsewhere, then you may not. And so in terms of therapies, this diagnosis doesn't make an awful lot of influence. There aren't specific therapies that you'd use. And indeed, in terms of prognosis, it's very difficult to say what sort of phenotype is going to emerge from family members who inherit this. Finally, on to permanent neonatal diabetes of the young. So this is diabetes diagnosed within the first 3 months of life, which is extremely rare. Normally, people with individual with type 1 diabetes, it's over the age of 5. And previously, these people needed lifelong insulin treatment. Now, it's identified that there were mutations within a ATP-sensitive potassium channel. You can see that in the cartoon on the right, and that this channel actually had a sulfonylurea receptor. And using sulfonylureas would close the channel and enhance insulin secretion. So this led to a small number of people being isolated who could actually be transferred from their current therapy, which was typically insulin, onto sulfonylurea therapy. So having a major impact on those individuals in that their life was no longer dominated by insulin. So a series of 49 cases globally was published in 2006. And this was a follow-up publication in Lancet Diabetes Endocrinology in 2018, showing that the sulfonylureas being substituted for insulin generally had a preserved effect. So it wasn't a therapeutic impact that wore off and ultimately they ended up back on insulin again. This was a long duration impact. So very exciting data there. So just to pull monogenic diabetes together, key features that we use for screening within Wales and elsewhere in the UK. So diagnosis of diabetes below the age of 25 years in at least one family member, being off insulin or having measurable C-peptide, ideally 5 years after diagnosis. There must be diabetes in a parental generation and ideally parental and grandparental generation. These are typically beta cell disorders, so you wouldn't expect to see evidence of insulin resistance, such as the skin discoloration of acanthosis nigricans. Neonatal diabetes is within 6 months of birth, often without a family history, so presumably novel mutations, and then renal system diabetes is one of the transcription factor MODIs. So what about, back to our case, how does all this stuff influence the relatively common scenario that I first painted? Do we think he's got one of the rare forms of diabetes? Well, I guess the fact that he lacks a family history or is not aware of one would make that much less likely, apart from the fact that these conditions are all extremely rare in comparison to the common type 2 and type 1 diabetes. What about ketones? Is that going to have an impact? Well, I mentioned that his ketone levels were borderline, but there's no doubt that the old teaching that ketones and DKA only happened in type 1 diabetes versus type 2 no longer holds water. And it's not only the situation with the use of SGLT2 inhibitors in type 1 diabetes increasing the emergence of DKA in type 2, sometimes euglycemic, but I think in my experience, generally hyperglycemic. But there's no doubt that patients of African Caribbean background, generally speaking, can develop diabetic ketoacidosis, or that can be seen at diagnosis, but ultimately will go on to be treated with tablets rather than insulin. So having this sort of crossover between type 1 and type 2. What about antibodies? Well, antibodies are much more frequently requested these days, but they are relatively expensive and therefore not immediately available. I know in our laboratory, the samples are sent over to the Oxford laboratory for testing, and they're certainly not going to be instantly available. So antibodies ultimately may be useful, but I think at diagnosis are not going to hold their mustard. And then what about C-peptide? We hear and see a lot of the use of both urinary and random blood C-peptides today. But again, this is a test that is not immediately useful at diagnosis. We mentioned previously that after 2 to 3 years, if people have still got C-peptide, then it implies that they don't have type 1 diabetes. But at the diagnostic point, C-peptide levels can be seen both in type 1 diabetes if it's picked up early, or can be suppressed in those with quite severe glucose toxicity because of high glucose levels. So I'm afraid we're back to clinical reflection and clinical acumen. And I have to say that insulin in this sort of scenario does at least give one a safe period for reflecting on what the diagnosis can be. So the bottom line is that you can never be wrong initiating insulin, because it will control glucose in all of these scenarios, and you won't be risking missing a patient with type 1 diabetes who may develop diabetic ketoacidosis. But the reflection bit is important and should apply throughout the person's career with diabetes. So they shouldn't just be labeled at the onset, because the diagnosis can be wrong. And here's another publication from British Medical Journal in 1983 of a patient who'd been treated with insulin for 50 years and ultimately was taken on insulin because the diagnosis that had been made in 1927 was incorrect. So this is something that needs regular reflection. Just to go back to the case, what happened to him? He was admitted to hospital. He was treated as an individual with type 1 diabetes. He ultimately went on to have antibodies that were negative. His insulin dose over time became much more limited, to the point where he came off insulin, and 12 months later was receiving treatment with metformin only and achieving good glycemic control. So started with a diagnosis of type 1, ended with a diagnosis of type 2. So I'd like to thank you for your attention. I hope that was of interest, and I will pass you back to the main meeting.